professors in Korea. So we're going to start with a brief introduction by ourselves. Like I'm Dr. An from Korea, who are really interested in the BP treatment these days. And let's start with the introduction by Kim Young himself.
Nice to meet you. My name is Myung Kim. I'm working at Women's University. I'm very honored to be with Dr. Gilling. I think you are the Michael Jordan to me.
Then we can move on to the Min-Soo Chu, who is working in it.
Hello, Dr. Gilling. I'm Dr. Chu, Min-Soo. I'm currently working in 보라매 Hospital in Seoul. Also, it's my great honor to meet you today.
Right. The same for me.
I think we can start with a brief introduction. Like in Korea, there is quite interest regarding the BP treatment, including traditional method like TURP and the advanced method including OLAP. And again, aquablation and some of the minimally invasive therapy options are quite being more available these days. So that is why we are quite interested in those kind of treatment options. Maybe you are the one who can guide us to a better treatment option choosing. So, yeah. So we can start with some of the questions I gathered yesterday. First one would be, what are the mechanisms considered to cause retrograde ejaculation? These days, some of the guys think that is not the retrograde, but dry ejaculation. So how about your opinion on that?
Well, you're probably aware that when you're doing TURP or HOLEP, if you spare the area around the veru, the paracallicular area, just as you do with aquablation, then you can normally achieve antegrade ejaculation. We used to think it was to do with the bladder neck and various things, but there was some studies showing that that's the important area. And so if your patient that's very important to your patient, then you can consider that, and you'll know from your aquablation experience that that area is left untouched, and the channel is anterior, and you look down and there's the veru and there's the paracallicular tissue all intact, and that's why they have antegrade ejaculation. So it's just a case of sparing that tissue with whatever technique it is you're using if you want to achieve antegrade ejaculation. And the HOLEP studies that have been done have shown that it's successful. It's more about 50% of the time, because you do take away a lot of tissue with HOLEP. So it's not as reliable in terms of retrograde ejaculation as aquablation is, but that seems to be the way to preserve. The so-called, they call them the buckets. Things. You've got an extraordinary amount of experience with aquablation. So, what have been your results?
For now, more than 80, but close to the 95 when it comes to the small prostate, like less than this 50 grams of the prostate. But when it comes to the prostate quite large, like more than 100, the percentage of the preservation is quite low, like less than 70%, I guess, in the real world. Yes. So, when it comes to HOLEP in Korea, as my personal experience, I come to realize that there are less than 20% of the people that have the preserved ejaculator function. So I just want to ask that if there are any specific way of preserving the paracollicular tissues, like 1 centimeter or
1 centimeter is what the study. There's been various papers on that. In our society, with the age group that we're dealing with, dry ejaculation is not a problem. So we counsel everybody that they're going to get retrograde ejaculation, and if they don't want to have retrograde ejaculation, they have to choose a different treatment. It's so uncertain.
It's quite a matter of consultation before the surgery.
Yeah, is it very important for your patients? Because for our patients, it's of virtually zero importance.
Gilling, do you think is it important to reserve the peri-ejaculatory fluid for the preservation of the ejaculation? Do you think is that important?
That's correct. Just that sort of about a centimetre in but I very rarely do that, because in our population, it's very, very few people are bothered by retrograde ejaculation, and a lot of them aren't sexually active, and it's of no concern.
About 10 years ago, I wrote some paper about the ejaculatory fluid technique for HOLAP. At that study, we did the ejaculatory fluid preservation about 100 cases, but the result was not so good. Almost more than half patients lost their ejaculation despite of the ejaculatory fluid sparing. So,
yeah, I would agree with that. If it's very important to the patient, then don't have a HOLAP, because it's not even with sparing, it's not certain.
Maybe preserving the ejaculatory fluid cannot solve all the problem. What do you think is the next mechanism we should enlighten?
For what?
To preserve the function, I guess.
As I say, it's not important in our patients. We tell everybody who's having BPH surgery to expect dry ejaculation. So, and in our society, it's not important. So, as I say, you need to choose a different technique, and resume or Eurolift or one of those procedures is probably going to be a better option for them. Or aquablation.
Maybe. So how do you think about the concept of preserving the interstitium, I mean the bladder? How do you think about that kind of theory on that mechanism?
Yeah, we don't spare the bladder neck with HOLAP. We try to mimic open prostatectomy and disobstruct the patient to the maximal extent and have the best durability, and that's why enucleation is so popular.
To follow the virtue of the HOLAP, like the strong point of the HOLAP is the low recurrence rate after the surgery. So we have
it's very low recurrence rate. In our follow-up from our randomised trials, it was less than 1% after 6 years. So the retreatment rate with enucleation is very low, as you all know.
Okay. Can we move to the question? Or
I experienced about 1,000 cases of HOLAP and 100 cases of aquablation. These days, I think after experiencing aquablation, I have removed too much tissues for BPH treatment during the HOLAP, because I think in my first experience, after the aquablation, I think the cavity is too narrow after the surgery. So I thought the patient may I worried about the patients if they can void it well, but almost all patients are voided well. So after that, I removed too much tissues during prolapse. I think so.
Yeah, that is definitely a criticism of nucleation, whether it's robotic, whether it's open simple, or whether it's endoscopic. There is, we know that most patients do not need to have that much tissue removed, and we know with TURP, you remove only half the amount of tissue that you remove with enucleation, and get a very good durable result in most people. So that's certainly true, that enucleation, however it's done, it takes away more tissue than most people need. Yeah.
Maybe it's somewhere between the whole and TURP. Like Aquablation would be the optimal option for some of the patients.
Well, we saw in the OR yesterday a patient who'd had one lateral lobe removed and the other one left behind, and that was 16 years ago.
Yeah.
And he came back for the other lobe to be removed, mainly because of hematuria. He'd done perfectly well from a symptomatic point of view for that many years, and if he'd been an older man, that would have lasted him. So that's just a good example of other modifications.
Like halfway whole leg or so.
Well, if you've got a very large prostate and you're not very confident with the procedure, then removing one lateral lobe will be more than enough for most people.
Really?
Yeah.
So next question is, I think it is quite relevant to what we are discussing right now. Aquablation seems to leave some adenoma tissue at the near travel clock.
Aquablation?
Yeah. And some residual tissue, maybe the floppy tissue, appears to remain. Could this become a problem in about 10 years later after the surgery?
Well, we know that the recurrence rate when you remove less tissue than enucleation will always be higher, but it'll still be quite low with any of the cavitating techniques. So the 5-year results from the water study showed that it was equivalent to TURP, but it wouldn't be equivalent to enucleation. There'd be a higher recurrence rate. But as I say, in the randomized trial, 5-year results were showing equivalence to TURP. Which does imply that it won't be as good as HODEP for that particular variable.
When it comes to the comparison between HODEP and Aquablation, I searched in the internet that there is ongoing research on the comparison between the HODEP and Aquablation.
Yeah, there's a German study which is a randomized, which the name of it escapes me, but that'll be interesting. I'm not sure how good those guys were at enucleation, so hopefully they got the learning curve out of the way before they started on the randomized trial. We'll wait to see, but hopefully they were experienced at enucleation, and it'll give us a fair result. Because if they were not particularly good at enucleation, it'll make that look false, make that look worse in terms of operative time and the amount of tissue that was removed. So, yeah, I'm looking forward to seeing the results of that study.
As a kind of a big father in the research industry, I guess you already know the preliminary results of the research. So, not yet.
Yeah, I haven't seen any, at the AUA this year, and I'm on the abstract review panel as well, and there was nothing at the AUA, and I'm not sure if there was any preliminary results at the EAU, but I'm unaware of any publications yet from that trial.
Okay, for that.
Do you think the remove the reserve the anterior tissue? Do you think that tissue have some laws for the preservation of ejaculations?
I'm more interested in continence, which is the reason when we originally started doing enucleation, the incisions were at 1 o'clock and at 11 o'clock for the top of the lobe, and so there was always some preservation of the anterior tissue, and the incontinence was a lot less than it is now, where people are going, all right. So continence is more of my focus. As I say, the retrograde ejaculation, is dealt with by the mists, the minimally invasive treatments. So the main focus by sparing, and you'll know there's various techniques that people have described, like the omega technique, where
leaving some of the tissue.
Where there's a distinct strip of tissue left, and incontinence rates were less in that comparative study. But the continence is way more interesting to me than the retrograde ejaculation.
Continence rate is quite well researched, studied regarding maybe the radical surgeries like robotic and open prostatectomy. Maybe some of the articles said that according to the anatomy of the external sphincter, it is quite important to leave the tissues or the mucosa near the travel clot, where the base of the urethra, near the vermiculum. So, how do you think about the population techniques character that leave some of the tissue on the anterior side would be helpful with the preserving the continence function?
Well, the continence is good after aquablation, and so you're sparing tissue adjacent to the viru, and you're sparing all that tissue anteriorly. So you're still achieving a reasonable channel, similar to TURP, but not as good as enucleation. And I think because you're sparing all that tissue, the continence is better, and the retrograde ejaculation is better, but the durability won't be as good. So it's trade-offs.
What is your rate for the stress urinary incontinence after the whole lap surgery? The incontinence rate. How many? How frequently?
If we go right back to the FDA study and the randomized trials that we did in the late 90s and early 2000s, and we had 6-year follow-up, I think, on some of those patients, and the incontinence rate was very low. But I think we're doing a more radical HOLEP now than we were doing in the old days because of that 1 o'clock, 11 o'clock technique. So the transient stress incontinence is pretty common with all the large prostates over 100 grams, and I tell patients to expect it, and if they don't get it, then they're pleasantly surprised. But I think it's just a function of the fact that we're all removing even more tissue than the early descriptions of HOLEP. So but there's lots of data out there looking at the 3 and 6 month resolution of the incontinence, and by 6 months there's only a few % of people that are still bothered. Is that your experience?
Do you have any other solutions for the patients? For example, some medication or?
No, we don't routinely start patients on any medication for incontinence. We wait. And I don't think anticholinergics or any of those type of drugs make any difference. What do you do?
Sometimes we have to do something for our patients so that patients can feel kind of loved and confident after the surgery. So I usually prescribe some of the medication like anticholinergics and some imipramines and maybe sometimes Cialis, tadalafil to make the vascularity a little bit better. Yeah, so that the patient can have confidence in at least at the ED.
Do you wait to see if they're incontinent before you start that, or do you start that anyway?
No, excuse me?
Do you wait to see if incontinence is a problem, or do you start them on those drugs preemptively?
Not preemptively.
No.
We we arrange a follow visit as just 2 weeks after the surgery, so that we can see if there is any stress urinary incontinence or not. So if there is any incontinence come out to be happen, so we are prescribing that kind of medicine so that they can feel loved. So we are doing that.
Yeah.
I like the duloxetine. Duloxetine, in some patients it has actual function, and duloxetine.
It's like to relieve the constipation that they have.
Oh, right. A laxative.
Yes, there's a laxative.
Yeah.
In Korea, that drug is permitted for or private prescriptions for the stress incontinence patients, and in some patients that has some actual effect. It is known to the sphincter tone. That drug makes us the sphincter tone. So I think some patients has effect after their medications.
Interesting.
After whole lab or a radical prostatectomy.
Interesting.
Yeah.
I must try it. Yeah.
I will too.